Good afternoon. Welcome, everyone, to today's Best Practice in Education rounds. I'd like to begin with an acknowledgement on the land which we work, study, and live. We recognize that many Indigenous nations have long-standing relationships with the territories upon which the Center for Faculty Development, the Wilson Center, are located on that precede the establishment of the University of Toronto, Unity Health Toronto, and the University Health Network. We acknowledge our presence on the traditional territory of many Indigenous nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, and the Haudenosaunee and Wendat peoples. Today, this land is home to many diverse First Nations, Inuit, and Métis peoples, and we're grateful to have the opportunity to live, work, and gather on these territories. We acknowledge that Toronto is covered by Treaty 13 signed with the Mississaugas of the Credit and the Williams Treaty signed with multiple Mississaugas and Chippewa bands. Since these rounds are a virtual gathering, a singular land acknowledgement doesn't capture the richness of our distribution across many locations. There are few places on earth that someone before us has not called home. I encourage you to consider your own position with regards to the land in which you find yourself. And if you are not sure how to locate these Indigenous territories, treaties, and languages that shape both the past and the present of your current location, I invite you to take a moment and look it up now. One of the benefits of this virtual format is that we can engage with virtual resources. So take a moment and open up another browser window, type in native-land.ca. So I'll say that again, native-land.ca. It's a crowdsourced interactive map, and it's built around the principles of land as pedagogy. The intention is to use these resources as an opportunity to critically engage in discussions about colonization, land rights, language, and Indigenous history. And land acknowledgements are only just a starting point we acknowledge for the larger conversations that we need to have. More concrete acts of restitution and transformation are needed to address the underlying inequities and blatant discrimination in the distribution of resources between Canada's First Peoples and settlers. And with that, let me introduce myself. My name is Latika Narula, and it is my pleasure to welcome you all today virtually to the Best Practice in Education rounds and to kick off our new academic year and my beginning term as the new director of the Center for Faculty Development. Today, we're exploring the topic of simulation for transformation, rapid transformation of health services and education, and we'll revisit 3 case examples of adapting to the COVID-19 scenario. Now, for those of you who know me and my own academic and program interests, you'll know that today's topic is very near and dear to me. So please note that this session is being streamed and recorded by a live Zoom webinar, and it'll also be archived throughout the CFD website. I need to go through a few housekeeping details before we can get started. So for those of you who want to ask a question or have any comments throughout the presentation, please use the chat option specifically for discussion and the Q&A box for any questions that you may have. We'll be responding back to the questions throughout the presentation as best as we can, and we'll hold the Q&A period at the end for any additional questions as we have time. And I'll also remind you to fill out the short evaluation that will be emailed to you at the end of the session. Your feedback is important to us. And with that, let me formally welcome today's panel moderator, Dr. Ryan Bridges. Dr. Bridges was trained as a kinesiologist at the University of Waterloo, and he went on to obtain his Master's of Science and PhD from the Institute of Medical Science at the University of Toronto. He completed an NSERC postdoctoral fellowship with Dr. Glenn Regehr at the University of British Columbia. Dr. Bridges now conducts research on how we learn to learn, and in particular, how we can integrate that learning into systems of technology-enabled and workplace learning. He's now a scientist and an associate professor in the Department of Medicine and IHPME at U of T, and he holds a professorship in technology-enabled education at Unity Health Toronto. Dr. Bridges is also the Director of Research at Unity Health Toronto's simulation program. So it's my pleasure to welcome Dr. Bridges as well as the rest of our panel of simulation educators to today's Beeper session.
Thank you, Latika, and for the invitation and the opportunity to speak and moderate this great group of panelists. I'm looking forward to the questions that are generated during the talk today. I think it's going to be very informative for us all. I do have a few points that I'd like to make as we lead into this. And it's that COVID-19 care readiness, the needs generated by this pandemic have positioned simulation, and by simulation I mean any form of replicating clinical care and the related systems of healthcare using any kind of technology, and you'll see that includes a broad range of technologies. This pandemic has really positioned simulation as a must-have, first-choice resource in many healthcare organizations across the globe. Indeed, there have been reports of its successful use from places as far as Canada to the Netherlands to Australia and to Lebanon. And I know that because I'm going to insert a little plug here. I'm a senior editor at a journal called Advances in Simulation and have had the opportunity to read many of these reports and learn from them. And so I encourage many of you to take a look at those as well in that journal and in many of the partner journals across the landscape. But like most expensive resources, simply having the technology in hand does not ensure that your organization will meet its most pertinent needs, especially in these time-sensitive moments that we've all experienced at the height of the first wave. And again, now, here we are entering the second wave. So as you'll learn from the three presenters today, implementing simulation well requires systems integration. But what does that actually mean? We hear that term a lot. What does it actually require? Well, what we've learned and what I've learned from reading other reports is that to do this well, the reality is that those on the front lines of simulation must partner with healthcare system leaders from across multiple portfolios: education, infection prevention and control, senior leadership, and all clinical practice leaders, as well as individual healthcare practitioners, trainees, and the patients and families they care for. It's a big operation to do this well. And so simulation teams have had to build reciprocal partnerships, and this generates legitimacy, goodwill, and the momentum that they need to propel their strong work. And so actually accomplishing systems integration requires listening, adapting, and failing fast to understand the path to good enough. Because I think we've all learned that waiting for perfection is not an option in these time-sensitive moments. So in the following three presentations, representatives from three sim programs, and I'll introduce you to them, here in Toronto will share their stories of how their teams helped their organizations adapt and respond to the demands imposed by this pandemic in early 2020, and I think ongoing as the year has progressed. Someday we'll be out of 2020, right? And so how timely this is, given we are entering the second wave as we speak. We just went above the peak of the first wave yesterday here in Ontario. And so I think we have some work ahead of us. And so Christine, Fabienne, and Jordan will now tell us how they've used a range of simulation modalities to prepare staff for redeployments, to address virtual care needs for our patients, and to ensure academic continuity for our learners and trainees. I believe I have the sequence right, but I might be a little off as we've made decisions on at last minute here. But starting us off, I believe, will be Christine Legere. And she's a physiotherapist and simulation educator here at St. Michael's Hospital, where I am. And she's an avid sailor, so you can talk about that with her post presentation. Next will be Fabienne Hargreaves. She's a community health and education specialist working in the Simulation Center at the Center for Addiction and Mental Health here in Toronto. And she has a master's in education to support her work. And then finally, the third case will be presented by Jordan Holmes, who's the senior manager of the Center for Learning, Innovation, and Simulation at the Michener Institute of Education at UHN and the School of Applied Health Sciences there. Jordan is now completing his PhD with the Wilson Center here at U of T, and so I get to work closely with him and learn from him. So that's all from me for now. As the session progresses, please use the Q&A option to type in questions that you have on the fly. Latika and I will try to answer the more general questions as we go, and those that are specific and require further discussion from the panelists, we'll hold until the end and we'll all discuss together as a group. Okay, I think we can turn it over to Christine.
Great. Thank you, Ryan. So hi, everyone. So I have the pleasure of starting us off with case number 1, so testing a new model of care, which includes clinician redeployment. So the word redeployment used to be a scary word at work, but then became the norm as we all had changes to our roles due to the pandemic. So I'd like to share with you how we at Unity Health Toronto use simulation to respond to this special case of redeployment. Okay, perfect. So in the early days of COVID, no one really knew how significant the surge of cases would be. Initially, I think it was thought that we would be impacted like our European colleagues. So as a result, the Toronto Academic Health Science Network, or TASN, the leaders there created a suggested model of care that would then help organizations in the event that there might be a significant staffing shortage due to COVID. So each organization was then faced with, okay, how best are we going to implement this new and significantly different model of care? At Unity Health, this was a significant change in practice. So as you can see, shifting from a one-to-one model of care to more of a team-based or pods model concept. And from the pictograph, you can see that a critical care nurse essentially takes on more of a team lead role and then is supported by non-critical care nurses to look after a number of patients within a critical care ward. So because of these changes, our executives then reached out to the simulation program to see if we could assist with figuring out how best to implement a different model of care here at Unity Health. Slide. Perfect. So why simulation? Well, we knew that this shift in practice was going to be huge for many. So it was imperative to have a process whereby people could provide input and have their voices heard and supported. We were able to accomplish this with simulation by bringing frontline staff to the table to discuss and simulate how best we were going to be able to operationalize this model and identify things like workflow processes, different communication strategies, and really describe innovative ways that perhaps the non-traditional clinicians could contribute to this new model of care. So our approach at Unity Health looked something like this. Our simulation team created multiple opportunities in the forms of various tabletops, so both virtually and in person, as well as in situ simulations. So these tabletops really allowed for us to get frontline interprofessional members to come sit at a table and discuss how to operationalize this model of care using hypothetical caseloads. And discussions, like I mentioned before, really surrounded things like communication and role clarity with people working within these pods. The teams were able also to identify what challenges they may foresee working within this new model and could brainstorm potential solutions. So I'm briefly just going to take you through each approach. So first we started with our virtual tabletops over Zoom, which is the new platform we've all come to love and know. So we did this with two different interprofessional groups. We first provided them with a high-level overview of what this new team-based pod model concept was and this new model of care, and then had facilitated discussions using hypothetical caseloads. Sessions were all recorded and scribed, and so all of that information was then collated and provided to various educator and leadership groups. Slide. The in-person tabletops took place after this, and we did this with our St. Joe's team members, where we had both critical and non-critical care members together. We had them at the table with a hypothetical caseload, as well as a floor plan of their unit and a little Lego piece to simulate who they were. And we had them discuss how they would prioritize patients, deal with plans of care for these patients. And then we prompted them with questions to figure out how they were going to deal with different situations as they came up. Slide. And lastly, we did in situ simulations, which allowed for us to really put this model into practice in the clinical care space with our frontline staff. Again, we did this at our St. Joe's site in an empty 4-bed unit and ran multiple scenarios that had to deal with mainly around a communication tool for transfer of accountability, but as well as medical scenarios. And it was really clear that that there was a need for training, which I'll talk about what we learned next. So overall, the use of simulation was a successful implementation strategy for this new model of care. And by scaffolding the approach from virtual to in-person to in-situ tabletops, the SIM program was really able to create a little bit of a feedback loop through those high-level reports to our professional practice colleagues. And in doing this, it allowed them to iteratively design and test guidelines, policies, and educate their staff accordingly. Now, historically, many healthcare workers work autonomously. And so by shifting to this new team strategy of the pods concept was really challenging for a lot of people. Our simulations repeatedly showed that staff were overwhelmed by these changes and couldn't make decisions on their own. And that it was clear that there had to be direction from leadership, especially around clarifying what roles and expectations were for those people working in the pods. So we were able to provide guidance to our professional practice colleagues around the types and levels of support that our healthcare practitioners needed in order to implement this model effectively. And as the new model of care was designed to maximize people's scopes of practice, it became evident through simulation that the roles and responsibilities of those people working within the pods really needed to be hashed out and clearly defined. For example, there was a lot of confusion around scopes of practice and what people were able to do and if they were able to delegate or accept delegation from another healthcare practitioner. So this identified specific intra and interprofessional educational needs to ensure that everyone knew what their practice responsibilities were working in those pods. And lastly, communication tools were identified as a strategy and designed to enable effective communication, both within the pods themselves, as well as between pods. So for instance, transfer of accountability. These tools then also help to clarify roles and responsibilities by structuring conversations around who could do what and when. Slide. So we as a simulation team learned a lot as well, and I'm sure all of you can attest to, it takes a village to work through a pandemic. We quickly learned that having simulation leadership at decision-making tables was imperative, because without that, perhaps we never would have been asked to be involved in the first place. And like anything you try for the first time, especially during a pandemic, we really learned to experiment and fail quickly and well with multiple modalities. Slide. And lastly, I just want to take a moment to acknowledge our sim team, who really were exceptional at being nimble and adapting quickly during these challenging times. So thanks, team. Thank you.
All right, hi everyone, I'm Fabienne. As Ryan mentioned, I'm a simulation educator at CAMH, and I'm going to discuss how we as a Sim Center supported clinicians with the adaptation of virtual care. Okay, and then the next one. So I'd like to spend the next 10 minutes or so sharing with you our experience at CAMH, as we had to quickly pivot to providing our first ever online simulation in our Sim Center to meet the demand of our clinicians as they navigate through a global pandemic. So I'll provide a bit of an overview of how we went about identifying these needs for our clinicians and how we address some of those through virtual sim. I'll briefly touch on some of our challenges and our wins, and then end with what our lessons learned and maybe what the future looks like for sim at our Sim Center. So first, understanding our new context. So almost overnight, massive restrictions were placed on CAMH and pretty much the rest of the world. We had very few outpatient services remain in person at CAMH. Only essential visitors were allowed on site, and any in-person non-essential meetings or trainings had to immediately be shut down. So this resulted in work and clinical care largely shifting to the virtual space with pretty much little or no preparation. So CAMH, along with everybody else here on this call, was adapting to an entirely new way of existing. Next. So determining where to start. Without the ability to run trainings in person, we regrouped with our clinical faculty and assessed the new needs of our clinicians as they began to largely provide virtual care to many of our patients. So our faculty combined the information gathered from several needs assessments. We conducted these assessments by sending out surveys to clinicians and also receiving responses to specific questions that we sent out to team leads and educators to ask the rest of their team during their huddles. So essentially we had to determine what training would match the needs of our clinicians, but honestly also be feasible to create and run. So we really had to balance this urgency with the fact that both our clinicians and our clinical faculty were on the front lines of a global pandemic. So as a team, we landed on adapting our in-person suicide risk assessment simulation trainings into a virtual offering. Suicide risk assessments, or SRAs, are a required organizational practice outlined by Accreditation Canada. And so therefore, it must be a continuous training to a virtual offering would hopefully address both the inability to hold in-person trainings, but also provide clinicians with that identified need to learn and practice how to conduct SRAs virtually. So meeting our clinicians' need. So through our needs assessments and conversations with our clinical teams, we realized that there's quite a range of confidence, sort of perceived ability and need to support in conducting SRAs. So when we think of this in terms of Bloom's taxonomy, we saw the need to support clinicians in both the understanding level and the applying level. So to increase clinicians' capacity for those who are at the understanding level, our clinical faculty created a how-to document for clinicians. And essentially this document reviews the nuances and safety considerations when conducting SRAs virtually. This document also talks about tips and tricks for conducting them in the virtual environment, and also makes references to the policies that we at CAMH have in place for telepsychiatry. So essentially this document is intended to be circulated to clinicians and discussed through and worked through with their teams, where the team leads and team educators can support clinicians based on their unique needs. So, and then to increase capacity for clinicians who are at that applying level, and my actual focus of the next 10 minutes, was that we developed a virtual SRA simulation to provide clinicians with an opportunity to both practice or observe an SRA being conducted with a simulated participant, where then they debriefed about the sim and discussed the nuances and challenges about conducting SRAs in that virtual environment. So as this was both the Sim Center and our clinical faculty's first time developing a virtual sim, we definitely looked to the experts in literature to inform our work. So Simulation Canada and Society for Simulation in Healthcare, along with other organizations, definitely provided a lot of trainings and webinars, discussions and forums around how to adapt simulations to COVID-19, especially in the first few months of that pandemic. So we definitely took a lot of learnings from that. Especially because at the time there was very limited published literature surrounding virtual simulation best practices, particularly pertaining to the use of simulated participants. So as a quick note, simulated participants, or SPs, as we call them, they're trained mental health actors, and for the purpose of our work here at our Sim Center, they use sort of a quasi-improv approach to portraying a patient. So we use that literature that we did find surrounding more physical health virtual simulations, and we adapted what we could for our mental health virtual simulation. So while we were developing this training, there were a lot of key considerations that we had to discuss and make decisions around as a team. On the screen here, I've listed a few, but like, to be honest, this probably took the biggest amount of time and brain power as a team to decide on, to ensure that the virtual simulations were ideally as reflective of current society as possible, but also that we were using WebEx to actually enhance participant learning. So a few of the key considerations that we did have to decide on were things like, how much do we edit our original in-person scenarios to reflect the current pandemic, but also the political and civil activism that's happening right now in Canada and across the world? And does this current context change what type of underlying cultural competency learning objectives we're tying into this scenario? Of course, we want our patient profile to reflect the populations our clinicians are serving, but is there or is there not a point in which we'll accidentally detract from the SRA learning objectives, just given how short this training is? Other things like how does a virtual environment change the debriefing model that we should be using? And how do you try to establish psychological safety for our learners when participating in a simulation can be scary enough? And now we're adding a new virtual component to this. And just to add to that, how does participants being on camera versus off camera affect both the psychological safety of the group, but also what we call Zoom fatigue? And since simulation does require a certain level of safety and trust, how do you establish that when facilitators can't read the room like you would normally if this was an in-person session? So in efforts to just not try to copy and paste our in-person simulation trainings to our virtual training, we definitely had to consider all of these things and many more to try to make a virtual offering that's both safe, but also useful for learners given the new context. So the format of the training, our learning objectives for our SRA training were these three. Essentially, it was to conduct a suicide risk assessment with the SP, and then to formulate a level of risk with a colleague, and with that colleague discuss on what next interventions you would put in place for this patient. Next. So the format of the training, sorry, it is a bit small. I hope you guys can read that. Essentially, we started off with a quick icebreaker, a pre-brief of what to expect in this virtual space, and then we went straight into the simulation. So the simulation itself was 20 minutes. It was broken down into two parts. So part one, at this point, we asked all participants to turn off the camera, except for one participant who will be conducting the SRA with the SP. So at that point, we're only observing the SP and the participant conducting an SRA. And then after 15 minutes, the SP would go off camera or leave the room. And a second participant will come on camera, and those two participants will then be talking about what they think that level of risk is and what the next steps of intervention would be for this patient. After that, we took a quick break. Then we debriefed using the modified plus delta. And with time, we also had a little discussion outside of the simulation of just outstanding learning goals. We realized that as you know, this is a new time and a new environment to conduct SRAs. Clinicians are coming into these trainings with very specific questions already in mind, which might not necessarily be able to be answered through our structured debrief. So we just allow a few more minutes at the end to discuss about any outstanding learning goals. Next. So challenges and wins. So I would definitely like to note that we're still in the beginning stages of virtual simulation as a center, and we'll definitely be continuing to adapt these For some of our challenges, I would unfortunately say with it. So it's definitely taken some trial and error to determine the best way to give participants just enough information to be able to successfully log in, but not give them too much information at the get-go of our virtual simulation that we accidentally overwhelm them before they actually get to the stressful part, which is generally the simulation itself. Wi-Fi connection is something that we also work against. I also just got a quick note that my Wi-Fi is being a little bit unstable, so I hope it's working for everybody. You can hear me. But that's definitely something that we are constantly working against, as many of us are using at-home Wi-Fi connections right now. And yeah, we're just continuously trying to find the balance between offering learners a variety of ways to participate, right? So not just verbally, but chat or the whiteboard function or the polling function. And then not also increasing their cognitive load on the number of functions that they have to learn, given the fact that this is only a 2-hour training. Some of our wins for these simulations is our simulation itself lent quite well actually to the virtual environment. And the overall reception of virtual education and just the general learner's willingness to actively be the participant in these virtual simulations has been both surprising and great to see. In the next slide, I will briefly share some of the participant feedback from our evals, but essentially virtual seemed to add to the training and not take it away. And lastly, we also had a larger reach. So we definitely have a handful of new faculty that have joined the project since we decided to turn it virtual. And we've also engaged our physician and resident population as well, which historically they haven't attended yet in our in-person trainings. Next. So the reception, overall, we had great reception to the training through participant evaluations. Here are a few that I've highlighted to speak specifically to the technology and the psychological safety component, as these were two of the major considerations that we spent most of our time planning around. So reading that all the participants agreed that they felt comfortable and safe during a virtual simulation is honestly probably one of my biggest takeaways as we continue planning virtual simulations. You will notice that there's also a comment on technical challenges. We have made some improvements after each virtual offering, taking into account our facilitator debriefs, our course evaluations, and also the participant evaluations. But honestly, this is something I just see as inevitably fine-tuning and improving as we go throughout our virtual simulation journey. So maybe I'll just give you a couple more seconds just to read this slide. Okay, Laura next. And then, yeah, so looking into the future. So some of our lessons learned. As we continue on our journey as a new sim center at CAMH, it's definitely safe to say that virtual simulations are here to stay. COVID has forced our center to take the plunge into virtual education, and it's allowed us to learn how to leverage a new type of technology to enhance learning for clinicians. So we're continuing to learn a lot about what works and doesn't work regarding virtual sims. But some of our key takeaways are, honestly, surprisingly, we overestimated the amount of support that SPs would need to be able to adapt to the virtual environment. After reviewing the scenario changes with them, discussing some nuances on how to portray the patient through a webcam instead of in person, and a brief overview of how to use WebEx, they were completely good to go, the quickest to adapt out of all of us. While WebEx, as I mentioned, sort of does have so many different functions, right? The chat, the raise hand, the emojis, the breakout rooms, the polling function, the whiteboard, we found that using only the essential functions to the training was better than providing too many options and increasing that cognitive load for learners. For us, given the fact that none of us have actually facilitated virtual simulations before this, the learners were also more novice in terms of virtual care. We opted for a debrief model called modified plus delta. And essentially this model allowed for more directive feedback and ease of facilitation for our faculty, since we're all a little bit new at this, instead of the diamond debrief model, which is what we were using in person up to that point. And finally, our complement of faculty and learners, as I mentioned, seem to increase with the virtual offerings. And just to note for our future that as we continue to integrate these lessons learned from this pilot, we are now starting to create some new virtual offerings for simulation, including verbal de-escalation skills training and opioid agonist treatment sims. Next. So this pretty much is the end of my presentation. I'm far from a one-person team, so I just want to say a big thank you to all the faculty that have been part of this project. And also a quick note that I am happy to connect with anyone who has questions surrounding virtual sims and our experience at CAMH beyond the Q&A portion of this round. Over the last several months, I've created a couple of virtual simulation resources, including a tip sheet on some of the strategies that we use to conduct virtual simulations based off of the webinars and the readings that we've been doing over the past few months as a sim team, which goes into a lot more detail than, of course, I'm able to do in this talk. So I'm happy to share that document or any others with anyone who's thinking about conducting some simulations virtually. My contact information is on the screen. That's it.
Hi, everyone. Pleased to join you today to discuss this really interesting topic. As Ryan mentioned, my name is Jordan Holmes. I'm here representing the work of many people at the Michener Institute, and just going to walk through some of the examples of how we've adapted to the pandemic from an academic pre-licensure kind of perspective. Okay, the next slide, please. So again, just to set that context a little bit, Michener, we have our School of Applied Health Sciences, where we have a number of pre-licensure health professions who are preparing to challenge their licensing exams, preparing to go into clinical environments. So our context for simulation, it crosses many kinds of modalities. Next slide, please. Before COVID, what we were doing with a virtual sim or virtual conferencing perspective was, we would do some synchronous lectures or seminars from the staff perspective. Maybe if somebody was out of office, we might try to hold a department meeting. But post-COVID, it's, our experiences reflect many of those in the room here today. We're using virtual conferencing for everything. Synchronous sessions, we're recording it for asynchronous sessions, and moving into simulations. So all of the kinds of simulations that we do, we're trying to find virtual ways to do it as well. So procedural simulations, SP-based simulations, mannequin, hybrid, we're trying to find ways to use virtual sim and video conferencing to at least augment the kinds of sims that we would traditionally do. Next slide, please. So what's interesting or what's challenging is that, for so long, the targeted integration of all three of our performance domains in an authentic clinical context has long been sort of the key value proposition of simulation-based education, or at least certainly for us. So, you know, we have our cognitive domain of knowledge and reasoning, we have our technical domain with psychomotor skills, and then our behavioral or affective domain with, you know, teamwork, communication. So it's really this combination of all three of these domains that's long been really why simulation is such a great teaching tool and such a great assessment tool. But with the move to online simulation, we're in most cases eliminating the psychomotor domain, so that middle kind of technical piece. So the degree to which this is challenging from an instructional design perspective greatly depends on the learning objectives of the simulation and the level of the learner. So I'm going to go through a few different examples of Michener of where this idea has been important. Next slide, please. So Rudolph and colleagues theorized that a learner's perceived level of realism of a simulation, and hence his or her engagement in it, is a product of kind of three dimensions of fidelity. So first is physical fidelity, or the degree to which the simulation looks, feels, and sounds realistic. So this is the dimension that has been most threatened by the move to online, as we simply cannot recreate the sights, sounds, and smells of an authentic clinical encounter. Nor can we perform the complex and nuanced psychomotor skills that are essential to many of our scenarios. So next is conceptual fidelity, or the degree to which the cause and effect chain of actions in a simulation follows logically with what happens in real life. So this has been mostly preserved in online simulation. The equipment and mannequins that we work with, for the most part, have the same limitations that they've always had. Finally, there's the experiential or emotional fidelity. This is the often visceral feeling that participants get when participating in a simulation. They feel a sense of connection to the simulated patient. Heart rates are elevated and the stakes feel real. Interestingly, this was the dimension that many of us in the simulation team were the most concerned about, though in many cases this was very well preserved, as Fabienne did such a great job talking about. So the first example of online simulation that we created at Michener highlights that story. When the pandemic hit in March, we were just nearing the end of our winter semester. So we have a 3-semester kind of year, to be followed by our summer simulation semester starting in May. So this, in May, everybody's supposed to come on site and practice in really contextually integrated and realistic scenarios. So perfect timing from a pandemic perspective. So this didn't give our faculty much time to prepare for a semester whose main purpose is solidifying clinical skills prior to full-time clinical placements. So to give our faculty an extra week to prepare, our curriculum team, led by my colleagues Carrie Knickel and Nancy McNaughton, designed and delivered a common week-long module that was then opened up to all students, like a virtual module. This module focused on patient-centered communication in a context of heightened anxiety, uncertainty, and a loss of face-to-face communication. Next slide, please. The capstone experience for the students was participating in a simulation with an SP, or simulated participant, you'll see on the left. The learning objectives centered around compassionate communication and principles of conflict de-escalation. While this picture is a recreation of the scenario that we filmed with an SP in the role of the student, the real students were just as emotionally engaged. Much to our surprise, the feedback from students was very positive, and many referenced how real it felt. So perhaps we've been too focused on this physical dimension of fidelity to promote engagement with our students. The next slide, please. The next example of virtual sim that I'd like to share is live broadcasting of mannequin-based simulation in our respiratory therapy program. Here we can see one of our faculty, Jody Cervala, leading virtual ICU rounds for students who are at a distance. So in this case, students could see all of the patient's vitals and form a team to discuss a plan of care. And then Jody acted as their hands. They walked her through what interventions they felt were appropriate, and our sim tech was in the background, making sure that the consequences or the conceptual fidelity of the simulation was maintained. Yes, there was a loss in physical fidelity. Students were at home without access to their assessment tools and instruments. However, the simulation was still successful because the core learning objectives were about clinical reasoning and not psychomotor skills. Core psychomotor skills were mastered in a previous course. Next slide, please. Finally, I'd like to share the story of our radiation therapy faculty over the summer. They were fortunate because they had access to a very sophisticated virtual reality software package that mimics the operation of a real linear accelerator for the treatment of cancer. So they could join in these virtual sessions with this virtual linear accelerator. So usually over the summer, students practice with a physical linear accelerator on site at Michener, which is different than the real thing only in that this high energy beam is disabled for safety reasons. So they position simulated patients on the treatment bed and make sure that the mega electron volt energy beam is going to target the right places in the body. However, in the VR version, students have the ability to cover cross-sectional anatomy, review and critique the treatment volumes in 3D, and display doses to each of the volumes displayed, leading to a discussion of target coverage and optimal dose. This would have been impossible, or would be impossible to do using the almost real linear accelerator that we have on site. And interestingly, faculty reported that this year's cohort of students became very adept in their problem solving and clinical reasoning, sort of non-scientifically, but compared to previous cohorts. Next slide, please. So although anecdotal, this got me thinking about a study that was published by Jeff Chung and colleagues out of the Wilson Center. Here it was found that integrating conceptual knowledge along with procedural skills training was associated with improved skill retention and transfer. So Jeff's really good at coming up with these kinds of catchy names for things. So he called it blending knowing how with knowing why. And I can't help but think, but a happy accident of the pandemic with a move to online simulation with its heavy focus on the cognitive domain has led to, for us, a relative de-emphasis on the knowing how and a greater emphasis on the knowing why. I think the trick moving forward will be to understand this optimal balance of knowing how and knowing why, and determining when we absolutely must bring students into the sim lab to perform essential clinical skills. So as a new member of our team said to me recently, if you want to teach people how to swim, eventually they're going to need to get into the pool. Next slide, please. So just to summarize a little bit on some of the major lessons learned, we found that moving simulation online does pose a significant challenge to authentically developing and assessing performance-based learning outcomes. But virtual simulations are generally constricted to the cognitive and affective domains. And the limitations to physical fidelity do not seem to take away from any kind of affective engagement. So really echoing the experience of CAMH and what Fabienne was talking about, the students or the learners really, once they get into it, the technology seems to fade away a little bit. And I'd argue if this way of working and this way of practicing, even as a clinician, continues, perhaps this simulation over Zoom might start to look more high fidelity than doing so in person. Finally, the virtual medium has given us space to explicitly promote cognitive integration during simulation. So that's knowing how blended with knowing why. So it's allowed us to re-examine the degree to which we do that. Next slide, please. I'd really be remiss if I didn't acknowledge a lot of the work of our team, including our faculty. I know some of our RTs are here today, our EV team, our broader SIM team, and our curriculum leads. And maybe I'll just go to the next slide and just pop up the references to Jeff's work and some of that conceptual work by Jenny Rudolph and her colleagues. And with that, that's me. Thank you.
Ryan, you there? There you go.
am.
All right.
Okay, so during the presentation, we had 2 questions for the panelists, and I'll address them in turn. I saw Fabienne addressed one from her perspective at KMH, but I think, yeah, we can hear from across the cases and programs. And so I'll just repeat the first one for the group. This is from Samantha Tipano. Could each of the panelists speak about timelines for when simulation was triggered, initiated, and whether there was consultation with other areas in the city, province, country, and the world that were further along in their first wave to learn from their experiences as you made the changes and adaptations to your program offerings? So why don't we start with Christine, and then we'll just work in the order of presentation, if that's okay. So Christine, did you work with others, and how were the timelines from beginning to actually implementing?
So I have the manager, Lindsay Beavers, here as well to help with this answer, mainly because I was on mat leave at the beginning of this pandemic. So I'm not sure what really triggered the timelines. However, a lot of the simulation practices started in our center back in February or even January, actually. And this kind of came down the pipeline because we are lucky enough here at St. Mike's to have 2 intensivists that are Italian, and we're able to liaise with their colleagues over in Italy when the pandemic really was getting, when COVID was really hitting them hard over there. So initially our simulations started with PPE and how best to don and doff proper PPE. And as we kind of moved through the months, it became clear that the TASN group had created this new model of care. So our simulations shifted from PPE to more of the model of care structure. And at that time, I believe it was really informally with our different hospitals around Toronto through Twitter and emails, trying to figure out how best to use simulation and implement these changes. So Lindsay, do you want to chime in with any additions?
No, thanks, Christine. I think you covered a lot of it. The only additional piece that I would add, I'm going to pause here because we're in the same room, we're echoing. We're going to try this with the mask on because she's sitting right beside me. The only additional piece that I would add is that we also did a lot of work around how to respond in an emergency. And so really thinking about how to support our resuscitation teams, getting in and out of rooms safely, and when there are aerosol generating medical procedures, how best to support our clinical folks. That would be one additional piece. Thanks. And apologies for the feedback.
And maybe just mute Lindsay on your computer. Great. And Fabienne, experience working with others, the timelines that were triggered, initiated, please speak to those points.
Yeah, so similar to St. Mike's, our focus at the beginning was a bit different. It was more on PPE. It was more about simulations for protected code blues. And then in terms of our actual SRA trainings, in May, we started with a discussion of maybe we can kind of do something with this. And we had our first faculty meeting in the middle of May, started conducting needs assessments. All of the training was done towards the end of June. So in terms of faculty development, how to use WebEx, how to train, how to do some virtually, and also our SP training was all done at the end of June. And then the pilot of this simulation started in the beginning of July. And then we've done 4 renditions so far since then.
From the Michener perspective, we pretty much transitioned right away in March where as much as we can, sort of sims that were, it really started with the SP-based sims. So that was the easiest for us to transition into. It was challenging sometimes because a lot of our SP-based sims also have a big component of physical assessment kind of attached to it. And this maybe partially addresses a further question as well, where we were trying to kind of play with this hybrid simulation idea where we would have some people in a sim lab and then an SP joining via Zoom. We had kind of some success with that, but it's really challenging because it adds a whole layer of working memory overload with your faculty and your students and your SP. Outside of that, resources that we engaged with at first, Simulation Canada was hugely valuable, as Fabienne was talking about. I had let my subscription to the Society for Simulation in Healthcare lapse, where you can join the forums and stuff. That was the first thing I paid for when the pandemic came, was to be able to go back in there and brainstorm with other, sim ops people or other educators. So that was really valuable. And it was a lot of the network of people you're seeing here. I would bend Lindsay's ear, or other people about what are we doing and how do we do it.
Great, thank you all. Another timing question asked by someone anonymously. Did the anticipated timing for sessions work, or did you need more time for different elements? So those who are attending can find that in the answered questions. Fabienne has offered an answer. And so again, Christine and Jordan, how did the timing work? And I'll just add to this, this idea that you were creating feedback loops between practice-based knowledge with practitioners and the data that you derived from the simulations, and kind of failing fast and trying to adapt. So how did that all work into the timing of what you planned and what actually occurred? Christine, please.
Just unmuting, making sure that I can be heard here. So the timing for everything that happened in COVID, as you can imagine, happened very quickly. We had to do quick turnaround times. We failed quickly, and then on a dime, we had to readjust based on the feedback that was given. And all of the information that was collated from doing our simulations was brought up the pipelines as quickly as possible. Everything had to be turned around very fast, as you can imagine. As I'm sure the frontline staff can attest to, guidelines changing every day, policies being changed literally minute by minute. So that's where that came from. And sorry, was there a second part to that question, Ryan? Okay.
Sorry, what was the question again?
Yeah, no problem. Did the anticipated timing for sessions work, or did you need more time for different elements? And if so, what were those elements that kind of amplified the time?
Yeah, so this actually partially addresses one of the other questions that was in the Q&A as well, of what did we do about group sizes. So for us, one of the decisions that we made was to actually increase our group sizes. So our typical group sizes would be like 8 to 1. And then often what we did, partially to try to give faculty some more bandwidth and time to prepare, because we were designing as we were going, was to move to 16 to 1. So to combine those lab groups. So with these simulations being very driven now as a cognitive exercise, and we didn't have the same requirement for everybody to get time on task with a part task trainer or whatever. We felt that that decision was kind of justified for our objectives. But what we did find is that what we needed to do was to account for more time for briefing and debriefing. First, briefing, because people needed to be orientated to this new space. What's different about the space? What are the limitations of reality that we're dealing with? And then for debriefing, to give everybody that voice and to give everybody that chance to share their experience and to do that key reflection.
Okay, and thanks for beginning to answer that additional question. And I'll turn that over to Fabienne and Christine. How many students or learners, professionals were involved in each simulation session? And were there individual assessments for either individual trainees and practitioners or groups built into what you did?
So in terms of learner numbers, normally for our in-person SRAs, we cap it at around 12 to 14. And then for our virtual trainings, so far we've opted to go into smaller groups. So our number that we strive for is around 8 to 10. We find that, well, we're worried that if we have too many, people might want to sort of just take a back seat, especially if they're not the active participant in the virtual space, and it might be a little bit harder to get them to not just feel anonymous in the small space that we're in. So so far, the lowest we've had was 6, and the highest has been 10, and so far that's working quite well for us. In terms of evaluations, so we don't have sort of any sort of evaluation or assessment of each individual. This isn't sort of a summative assessment by any means. It's just sort of clinical clinical practice and just clinical practice. But as part of our Cooper evaluation, or Cooper, we did ask to do sort of a focus group with the learners, so where they self-assess if they've actually improved any of their SRAs virtually after, I think it was 3 months and 6 months post-training.
Yeah, so our number of learners was slightly different, as we weren't necessarily teaching curriculum, but more so using simulations for policy building and procedures. So all of the numbers really were obviously virtually. We could have as many as we wanted when we wanted the interprofessional teams together. It was really imperative that we had each member from each profession sitting at the table. However, we had to abide obviously by the OC Health and the government guidelines of capacity of how many people you could have in a room at what time when we were running these sessions. So when we did our in-situ simulations, as well as even our PPE training, it was capping numbers at 8 to 10, obviously based on the room size, making sure that people could abide by those guidelines set out that everyone's following right now. So we didn't really do evaluation or any type of assessment on our learners.
Thank you. And I think it's unique, yeah, depending on the objectives, of course. Do we have time for one more, Latika?
I think we'll do one last question, keeping our responses pretty succinct, and then I have a few closing comments to share with the group.
Okay, I'm going to try to combine 2 questions. So one from the Q&A, one from the chat. So given your experiences thus far in an ideal world where in-person sims are less limited, how would you integrate virtual sims that focus on the knowing why with skills that maybe need to be taught hands-on in person? And so really that breaks down conceptually to asynchronous sims, where maybe people could watch videos and experience simulation that way, and then synchronous, where there's some kind of coming together either physically or in the online space. So have any of you gotten experience with that or are planning to do so?
Maybe I'll go first. With the start of this fall term, we do actually have students back in the sim lab on a very limited basis, doing those essential kind of clinical skills where we feel like the move to virtual just not enable really a mastery of those skills. I think the way I'll answer this a little bit more is one of the things I'm a little worried about in the design or the instructional design of these simulations. If we start to kind of decontextualize too much of the cognitive piece, the affective piece with the psychomotor piece. The whole premise of simulation was its value in combining all of these together. So sometimes I do worry that kind of, chopping it up into little bits and fully pulling out just the psychomotor pieces and then using the time that we have on hand to really focus on that could in ways be problematic. But we'll have to keep thinking about that one.
So with that, I think we're going to have to close off there. And fortunately, we've run out of time to hear from the other panelists. But I think we could keep going on and on. I think we've really struck a chord with this topic. And thank you all for sharing your experiences. Special thanks to Ryan for being our moderator extraordinaire, and of course our panelists of Christine, Fabienne, and Jordan. I just want to remind you that to remember to fill out your evaluation. That should be hitting your inbox shortly if it hasn't already. Your feedback is important to us. Our next beeper round will be held on October the 20th from 12 to 1 p.m. And we're really excited to have Betty Onyura and Anne Vo will be presenting on useful to whom, program evaluation, utilization, and scope in good times and COVID-19 times. So I hope that you'll be able to join us for that. Make sure that you register on our website for that session. And with that, I would like to thank you all. Have a great rest of your day. Bye, everyone. See you in October.